So baseline characteristic in the population demographics were quite well matched. As we can see, high risk, nearly 90% patients were high risk. Bone marrow involvement was seen in nearly 3/4 of patients. Blastoid variety was nearly 7 to 8% of patients. Extranodal disease was nearly 85 to 90% patient. Nearly 1/3 patient has a bulky disease, and nearly 10% of patient has P53 mutated. Next slide. So what was the primary endpoint of PFS? Was median PFS at the end of nearly 7 years, so 80.6 months versus 52.9 months with HR of 0.75 and p-value of 0.00. So there is significant improvement in median PFS by 2.3 years, 6.7 versus 4.4 years, and there is 25% reduction in risk of progressive disease or death. So the PFS as a primary endpoint was made statistically. Next slide. If we see the forest plot, most of the patient subgroups benefited in this group except high-risk patient. As we might expect, we need additional high-risk aggressive therapy in such subgroup. But most of other low-risk, intermediate risk, and low intermediate risk patients, even the bulky disease and non-bulky disease, benefited equally. Next slide. So if we see the what was the PFS in the high risk subgroups, we can see blastoid and T53 mutation. PR had a numerically improved median PFS, though it was not statistically significant. So if we conclude in terms of median PFS in high risk patients, including P53 mutation, it was more than 2 years in combination with the ibrutinib plus BR versus less than 1 year. In VR alone. Next. So if we see the response rates, again response rates, CR is slightly higher. Overall response rates are more or less matching, numerically higher, but CR rate was higher in ibrutinib arm. Next slide. Time to next treatment. If we see, relapses happen more commonly in VR arm versus ibrutinib arm. So subsequent therapy at second line, ibrutinib has only 99% or nearly 20% patients required, while in placebo arm, nearly 40% patients or patients required second line therapy. Next. So what are the common treatment emergent adverse events? More than 20%. As expected, ibrutinib, in addition to BR, had its class effect and more side effects in terms of neutropenia, diarrhea. Then rash was quite common. Thrombocytopenia, anemia, pneumonia, infections were quite common in ibrutinib arm. Next slide. So if we see what are the chances, there is a high risk of chances of bleeding. Major bleeding was 5.8% versus 4.2, but any type of bleeding is nearly double that of what it was in the placebo arm. Cardiac side effects, especially atrial fibrillation, nearly 14% patient in ibrutinib arm. Hypertension, more or less similar, and arthralgia, 17% and versus 16.9%. So during the entire study, second primary malignancies, including skin cancer, occurred in nearly 20% patient in the ibrutinib arm, while 19% in the placebo arm. MDS and AML were also reported in 2 to 3 patients, respectively. Next slide. So the OS, if we can see, OS is more or less same. So and there was no statistical difference in the overall survival. And if we look at the death data, nearly 58 patients had death in the ibrutinib arm versus placebo nearly 70%. Next slide. As this period also included COVID, few of days were attributed to COVID. So to conclude, the median PFS in the ibrutinib arm was 6.7 years. It is giving nearly 2.3 years of PFS advantage. The adverse events were consistent and expected as profile of ibrutinib and BR. So it is definitely a new benchmark for the patients who are older subset and even in like low risk and intermediate risk group. Except high risk group, probably we need some better solution as we have seen in the subset analysis. Thank you.
Thank you, Dr. Mahajan, for quick and nice overview of science study. The next speaker